So I used to watch David Letterman all the time, and I always liked his top 10 list. So I thought maybe I would come up with the top 10 reasons why neurologists stopped ordering spinal fluid analysis. So number 10, the complaint that whatever they get, they can never be sure of the results. So the tests are always unreliable. That the tests are not reproducible. Sometimes they would get a yes, sometimes they would get a no, so they got frustrated and stopped sending spinal fluid. The whole idea was that CSF might tell you something about the diagnosis of MS, but now we have MRI, so why would you even bother looking at spinal fluid? Lumbar punctures, too much pain, not enough gain. My American colleagues tell me they don't pay them enough to do lumbar punctures. Then you have to listen to all the complaints of the headaches afterwards, so what's the point? Does anybody do these anymore? I mean, some parts of the world, they don't even teach you how to do lumbar punctures. The lab always loses the samples. You're going to go take the effort of getting a patient to lie down and get a lumbar puncture to get spinal fluid. You send them off, and then for some reason, nobody has the result because nobody got the actual tube. I already suggested that you don't get paid enough to do lumbar punctures. How about this one? I forgot how to do one. The last one I did was in my residency. That was 35 years ago. So why would I do this again? Number 2, too many false negatives. I know the patient has MS, and every time I do the lumbar puncture, it keeps coming back negative. What information can I possibly get from this? And probably the number 1 is that I know this patient has MS. So why bother doing spinal fluid anymore? And I think there's been enough evidence over time that spinal fluid actually is a reliable test, and used appropriately in the right context of trying to help you with a diagnosis is one thing, but what else can we learn from the brain soup? I mean, really, there are a lot of potentials, and that's what you're going to hear about, hopefully, in the next 30 minutes or so. You're going to hear about some of the potentials for biomarkers. What would we use such biomarkers for? The idea is that if there is certain information that you can glean from the spinal fluid, maybe we'd be able to choose the right candidate for the right drug. If there's something that we can measure, we can say, aha, this is somebody who will respond to this particular type of therapy. If there was a marker that the disease was getting worse, but the patient hasn't had any symptoms yet, as a preeminent sign of worsening disease, you might intercede with an escalation in therapy before the patient runs into trouble. We could perhaps use the biomarker to help screen out drugs that are unlikely to work in patients because perhaps they are impacting certain mechanisms, and those mechanisms from the spinal fluid tell us that's not going to work. We might use the biomarker to actually show that what we're treating the patient is working because something gets lower. If the biomarker is an indication of worsening disease and we lower the biomarker, that would suggest that we are winning the battle as opposed to losing. That idea comes into trying to determine if a patient is a good responder or a bad responder. Currently, the only way we know patients are responding to disease-modifying treatments is because they're not having any disease. But is that really a responder? Maybe there's something positive that we could use to measure. And we might even see where certain biomarkers tell us that a combination of therapies might be more useful than a single one. Just on the idea of responders versus non-responders, I want to raise this because I think it's an important topic. That responders, what we are calling true responders, are patients who are not having disease activity because the drug is working. So that's a true responder. We have a non-responder, and we can define that. And that's someone who has continued evidence of disease activity, whatever that level of disease activity happens to be. But there's this third group that everyone has to realize is there, and that's the false responder. And these are people who are not having disease activity because they're just not having disease activity. And it doesn't matter whether we gave them a drug or not. They would have done extremely well. How do you know who those people are? Well, the non-responders we define, and you're going to hear over the course of the day certain things that we've thrown out. The idea of NEDA, no evidence of disease activity, or some evidence of disease activity, and what level that is. We can define that. But we have no way of separating the true responder from the false responder. We don't know the patients whose natural history would be to be nothing, to have no disease activity. So when you apply a treatment, keep in mind you may have false responders in there, and especially if the treatment carries certain risks, you always have to be aware that you're maybe subjecting false responder to risks they do not need to take. Well, where does NEDA fit in here? No evidence of disease activity? Well, NEDA is going to fit right in there. And so you don't know how many of those false responders are doing NEDA, and they would have done it whether you gave them a drug or not. All right, what's a biomarker? What is a CSF biomarker in particular? And the whole idea of a biomarker is it represents, has something to do with whatever that biological process is that's causing MS. It may not be directly related, but it's so closely associated that movement of the biomarker is almost surely going to indicate movement of the disease activity. So it could be, for instance, a marker of natural history, so you can tell when the disease is getting worse and will correlate as the patients advance. Or, as we're thinking of it in the context of introducing new therapies, it can capture the effects of perhaps whatever the intervention is that we're doing because it's related to its mechanism of action. So there's a number of different biomarkers, and that's what we're hoping for. And this all has to do with our understanding of what's going on outside the brain, which is to the left here. And so there's biomarkers that are generated as the disease starts to brew, and there may be what we're talking about inside the brain, where the CSF is a marker of some of the damage that is going on inside the brain. Now, there has been a whole long list of these over the years, and that's what we're going to hear a little bit about. They've been used in the context of diagnosis. We've heard about it in the course of prognosis. We might be able to see it in necessarily the monitoring of treatments. People have looked at the number of B cells that are present in the brain as a response to rituximab, for instance. We've been looking for evidence of toxicity by looking at JC virus antibodies in the periphery or actual PCR inside, and a number of these have even looked at repair. So the long list here, I'm not going to go through them all, but they're categories. So there are some immune system related biomarkers, cytokines, chemokines, receptors, immunoglobulins. We can actually have a marker of the blood-brain barrier permeability. We can look at demyelination and myelin breakdown products. You could look at markers of excitotoxicity or oxidative stress. You can look at axonal integrity for things like neurofilaments, or you could even look for markers of gliotic scars like GFAP, which may be even more useful in neuromyelitis, which hopefully we'll hear about tomorrow. And we can even measure evidence of remyelination. There are some novel ones for future regeneration or repair. These have all been proposed as possible indicators of recovery, at least from the animal models. And the question really is, are any of these ready for prime time? That is hopefully what we're going to hear about from our two debaters here. And this is not an exhaustive list, but there's some here I'm sure that are going to be touched upon by our two debaters. So I'm hoping here that in the next little while we hear about feasibility, that hopefully it doesn't require frequent lumbar punctures, but there may be sequential lumbar punctures. When do we want to do this? If it's from a therapeutic standpoint, do we need to re-baseline? If we start a new therapy, do we have to repeat the lumbar puncture? How much do we need? It has to be feasible. If you need 40 cc's, that's not going to happen. Do we need to have a special lab prepare these? There may be certain aspects of the biomarker that can only be done on certain preserved fluids, like you have to put in an RNase to the medium to prevent the degradation of RNA. Eventually, we're going to need sensitivity and specificity to tell us that it's working. And maybe there is an alternative, and for years now people have been talking about using either serum or, believe it or not, your tears to look at what might be in the spinal fluid. So with that, I'm going to leave it to our two debaters to help us decide, and please don't forget to vote now for yes or no, and then we'll do it again afterwards, Emmas? Yes. Thank you. Oh, I'm going to wait for it. Is it going to pop up here? It's supposed to be on the app. Oh, here we go. Okay, so whoever has the no has the work to do. Oh, no. Still 2/3, 1/3. Where do you see the number? Oh. Who's got the no? You got work to do here. Well, I think we get the gist of it. So we'll see this voting afterwards as well.